The orientation of the patient, i.e. prone or supine, head first or feet first, will be dependent on the CT examination being undertaken and local protocol. For the majority of CT examinations, it is important to ensure that the patient's median sagittal plane is coincident with the centre of the table in the X direction, to optimise the entire scan field of view, SFOV. Laser localizers are used to position the patient accurately within the gantry. First vertically, by raising the table height in the Y-plane until the area to be imaged is level with the lateral laser line. This is typically the external auditory meatus for head CT and the mid-axillary line for body scans. The patient is then advanced horizontally into the gantry in the Z direction until the internal or external AP localizer corresponds with the anatomical landmark where the scan is set to start or finish, dependent on the direction of the scan. Optimizing CT procedures is important, and correct centering of the patient within the isocenter of the gantry is often neglected as part of this process. Firstly, it ensures correct application of the bow tie filter used to shape the beam across the diameter of the patient. When the patient is too high or too low in the gantry, one outer edge of the patient receives a more intense X-ray beam than the central-most attenuating part of the patient, which receives a suboptimal exposure. This results in higher levels of image noise. Secondly, isocenter misalignment in both X and Y planes impacts the correct functioning of automatic tube current modulation, ATCM. It specifically influences the uniformity of image noise and the MAS applied, which is measured and prescribed using the attenuation information for the patient, taken from the scan projection radiograph, SPR. Good isocenter positioning is essential for estimation of the attenuation profile and achieving correct dose levels, i.e. avoiding under or overexposure. The literature has shown that 4 cm offset results in 25% change in MAS. Some operators may be inclined to place patients below the isocenter because the CT couch is curved, so there is more patient posteriorly than can be visualized from the side. Also, some tables do not move high enough in the gantry, for example when scanning smaller patients or babies. Scanning children will be covered in more detail later on in this course in Section 6. If a lateral scan projection radiograph is being used, the scan table height should be adjusted and the scan projection radiographs repeated for the prescribed MAS to be correctly calculated. There are differences between CT vendors and between scanners from the same vendor, so it is important that radiographers know how their scanners work. In the future, a number of technology developments in artificial intelligence may allow us to precisely map patient landmarks, automatic positioning, and define scan ranges to overcome the challenges of poor isocenter alignment. However, underpinning knowledge and skills in the correct patient positioning essentially allows monitoring of these automated systems.
So to ensure a patient is accurately isocentered in the CT scanner, essentially that means that you want them right in the middle of the scanner. The easiest way is to use the laser lights that all machines will have on them. You should have 3, so you will be able to center them in the Z-axis, so basically your scan range from top to bottom. That laser line should be either at the top of the area that you want to scan or the bottom, depending on whether you're going to scan craniocaudal or caudocranial. So you also have laser lines in your X-plane, which is your sagittal or side-to-side plane, so you can ensure that the patient is central on the table. And then you have another lot, which is in the Y-plane, which is your coronal plane, or essentially how high or low the patient is in the scanner. So using all of those 3 in conjunction with each other, you should be able to line the patient up so they're nice and in the middle of the scanner.